So our next speaker is Nate Overholtzer, who will be talking to us about stimulant use in adolescent ADHD associated with attenuated and distinct cortical differences.
Good morning, thank you for the introduction. Again, my name is Nate Overholtzer. I'm an MD PhD student at the University of Southern California, training under Dr. Megan Herding. And today I will be speaking on how stimulant medications in adolescent ADHD are associated with attenuated and distinct cortical differences. I have no disclosures for this presentation, but if you're interested in further discussing this project, please come by poster number 272 this afternoon. I'd be happy to discuss it further. So ADHD is the most prevalent neurodevelopmental disorder. Estimates of the worldwide biological prevalence of ADHD range from 2 to 8% of youth, and in the United States, nearly 12% of youth have received an ADHD diagnosis. The high prevalence of ADHD makes the medications used to treat ADHD some of the most common neuropsychiatric drugs prescribed during development. Pharmacologic treatment of ADHD is an important first-line approach. Pharmacotherapy has the best evidence for mitigating symptoms and improving functional outcomes, and additionally, it has been theorized to normalize brain differences in structure and function inherent in ADHD. However, the field of neurostructural effects of ADHD pharmacotherapy has been limited, first by a lack of studies with direct comparison of medications within the same study population, and second by small homogeneous patient samples that lack diversity and statistical power. ADHD pharmacotherapy can be divided into two main classes of medications, the most common in the United States being stimulant medications, including amphetamine-based and methylphenidate-based medications, and prior literature suggests preferential response between stimulants and failure to respond to stimulants, yet the reasons behind these variability remain unclear. Second, non-stimulant medications are prescribed as an alternative to stimulant medications and include alpha agonists and norepinephrine reuptake inhibitors, and stimulant medications such as amphetamine and methylphenidate primarily act on dopaminergic and noradrenergic pathways, whereas non-stimulants primarily act on noradrenergic pathways with downstream effects on dopaminergic pathways illustrated in panel A. However, amphetamine and methylphenidate also differ in their precise mechanisms, including the mechanisms in which they increase dopamine availability and secondary agonism of receptors. Finally, there's regional variability in the concentration of neurotransmission systems, and we hypothesize that ADHD medications' effects would be localized to regions with higher concentrations of the targeted neurotransmitters illustrated in panel B. Thus, the objective of our study was to use the landmark US NIH-funded ABCD study, first to use an explainable artificial intelligence framework to identify potentially medication-sensitive brain regions, and second, to characterize the distinct neurostructural effects of amphetamine, methylphenidate, and non-stimulant use in relation to ADHD status effects in the brain regions using linear regression. The ABCD study is a 21-site U.S. neuroimaging study enrolling more than 11,000 children aged 9 and 10 years. And from the study, we identified over 700 subjects as ADHD medicated, more than 500 subjects as ADHD unmedicated based on parent response to a medication history questionnaire, and the Kitty Schedule for Affective Disorders and Schizophrenia, which is a semi-structured diagnostic interview. The remaining more than 7,000 subjects were labeled as a control group. Importantly, we excluded any subjects taking antidepressant, antiepileptic, antipsychotic, anxiolytic, or other neuroactive medications, and we semi-randomly selected one sibling per family for regression modeling to account for non-family independence, preferentially retaining siblings with ADHD. ABCD uses a harmonized scanning acquisition procedure across sites, and we quantified cortical thickness, surface area, and volume in 68 DK ROIs. Our analytical framework started with a machine learning approach. We used bootstrap logistic elastic net regression to identify brain features as potential targets of ADHD medications by predicting medication status. In other words, distinguishing ADHD medicated individuals from ADHD unmedicated individuals. And these features were weighted by performance at chance and selected in 50% of bootstrap iterations. And these ROIs were used for hypothesis testing in our LME regression modeling stage. Then we used linear mixed effect regression modeling to measure the discrete effects of ADHD, amphetamine, methylphenidate, and non-stimulants in these regions, while robustly controlling for other covariates, including sex, age, race, ethnicity, household income, parental education, MRI manufacturer, and random effects of scanner serial number. Our machine learning approach identified cortical features as potential targets of ADHD medications. Under our feature stability weight threshold of 0.25, we identified regions that distinguish medicated versus unmedicated ADHD use. This included 9 ROIs for cortical thickness, 2 ROIs for surface area, and 9 ROIs for cortical volume. The first thing I'd like to point out on our linear mixed effect regression slide is that all effects, regardless of significance, are mapped here. We will discuss the statistically significant results shortly, but focusing on the statistically significant results misses the broader pattern seen across all brain regions. So for ADHD, red indicates increases associated with ADHD brain relative to the control, and blue decreases in ADHD relative to the control brain. The same is true for medication use effects, with red indicating increases associated with the medication and blue decreases associated with medication use, here mapped for amphetamine, methylphenidate, and non-stimulant. The main takeaway here is that overwhelmingly medications appear to oppose the direction of our ADHD effects across brain regions. If a brain feature is increased in ADHD, then there's an associated decrease with medication usage compensating for these differences. To illustrate this, let's take a look at the right banks of the superior temporal sulcus surface area. We see ADHD is associated with an increase in surface area, whereas all 3 medication classes are associated with decreases in this ROI. When you subtract the effect of medication from the effect of ADHD, it brings them closer to the control phenotype, and this pattern upholds across ROIs, suggesting that medications are grossly counteracting ADHD effects, making their brains neurostructurally more similar to controls. Amphetamine and methylphenidate appear to compensate for and exceed the magnitude of ADHD effects, and non-stimulant medications appear to be associated with compensation directionally, but tend to fall short of the magnitude of the ADHD effects observed. Now to discuss statistical significance. So after FDR correction, there were no significant effects of ADHD or non-stimulant medications. What we did observe was significant effects of amphetamine and methylphenidate on reduced left posterior cingulate and right banks of the superior temporal sulcus surface area, illustrated here. And amphetamine showed 2 additionally statistically significant effects, including right entorhinal cortical thickness, this really small region right here, and left posterior cingulate volume. One of the main takeaways of this work is that stimulants appear to attenuate the ADHD brain cortical phenotype. We see that the medication effects contrast with the direction of ADHD effects. The effects of amphetamine and methylphenidate exhibited similar effect magnitude and direction, whereas non-stimulants exhibit similar direction to stimulants, suggesting compensation, but the magnitudes were weaker, falling short of ADHD effect magnitude. We saw statistically significant effects in the entorhinal cortical thickness, where amphetamine was associated with increased cortical thickness, and this is likely driven by the higher expression of dopamine transporter in that region. The banks of the superior temporal sulcus showed a decrease in surface area with both amphetamine and methylphenidate, and we theorize this might be related to expression of norepinephrine transporter in this region. And finally, the posterior cingulate was our most interesting finding, which showed decreased surface area with both amphetamine and methylphenidate, and additionally decreased volume with amphetamine. This is possibly due to both high dopaminergic and moderate noradrenergic activity. And this region was also interesting because prior work in the ABCD study using the same wave identified this region as the largest ADHD effect in the ABCD population at 9 to 10 years. However, our work suggests a near 0 effect of ADHD in this region, suggesting that stimulant use is associated with differences in this region rather than an inherent ADHD pathology. In summation, our study found that amphetamine and methylphenidate appear broadly to attenuate the ADHD cortical phenotype. Non-stimulants exhibit similar direction and effect to those of stimulants, but with a weaker magnitude. And additional research is needed to determine if stimulants are associated with overcompensatory and/or de novo effects in these specific regions. In future work, we plan to explore how these patterns persist or remit over the course of adolescence through longitudinal work and begin to explore possible confounding factors such as medication dosage and ADHD severity. I'd like to thank my advisor, Dr. Megan Herding, and the Herding Lab, my committee members, and the ABCD participants and their families. Again, I will be at poster number 272 this afternoon. Please feel free to stop by if you'd like to discuss this work further. And I'll open it up to questions.
Thank you, Nate, for this really nice talk. So we have some questions in the app, actually. So
Yeah.
the most upvoted one asks if you could clarify if people were already on medication by the time that they were scanned.
Yes, so in ABCD, we have data on medication history that gives an overall of the last 2 weeks at baseline, how frequently they've been exposed to a medication, but we don't actually know how many years they have been on that medication. I think that underscores the utility of future longitudinal work in the ABCD population, because you will have people who are newly exposed to medication and newly diagnosed, as well as people who go off medication. So I think that future longitudinal work will really be able to further and better explore medication over time.
Great, and maybe one more question. Here, people are asking if you looked at ADHD subtypes separately, like the attention deficient versus hyperactive subtypes in your analyses.
No, but that is a major direction of my dissertation work. Specifically, I want to look at differences in subtypes for symptoms, as well as indices of ADHD severity, as well as dosage, and sort of explore more confounding factors. I don't know if I have any more time for questions, but if you have questions, feel free to stop by my poster this afternoon. I would love to chat more about this project.
Awesome. Thank you so much, Nate.
Thank you.